All right, it's about 2 minutes after the hour, so we're going to go ahead and get started. Hi, everyone. My name is Amy Donahue, and I am Pivot's Engagement Officer. And I'm so excited to welcome you all back, or for the first time, to this 8th edition of our virtual panel discussion series, Voices from the Field. Today will be the first in a series of 3 panels where we're shifting our focus a bit to talk some more about our ongoing clinical activities outside of our response to COVID-19, but we will keep you updated each week on the status of the pandemic in Madagascar and what we're doing to respond to it. So today is going to be about community health. Next Wednesday, May 27th, will be about our primary care activities. And the following week, Wednesday, June 3rd, we're going to talk about our work at the district hospital. So we hope to see you on the line in the next couple of weeks. Before I hand it over to our panelists, I just want to go over a couple of super quick housekeeping items. So first, I just want to let you know that we are recording this session today, and we'll share a link to the recording within the next 24 hours. So if you need to drop or you'd like to share it with anyone, that will be available for you to circulate as widely as you wish. And secondly, we want today's session and really all of these sessions to be as interactive as possible. So we're going to aim to shift to a live Q&A about halfway through the hour. Thank you to those of you who submitted your questions in advance. And for those of you with questions on your minds now, please use the chat box down at the bottom of your Zoom application to submit any questions you have on your mind. And the earlier in the call you can do that, the better, so that we can organize ourselves to get to as many of them as possible. Lastly, if we do get to your question, you are on the line, we'd love to give you the opportunity to present your question using your own voices. So if we get to your question, Tara will say your name, I'll enable your microphone capabilities, and we'll invite you to ask your question. If you'd rather not, feel free to ignore us and we will proceed and ask it for you. And with that, I will hand it over to our Executive Director, Tara Lloyd, who will be moderating today's conversation.
Thanks, Amy. Also, for those of you who are eating lunch, eat away. We can't see you. Or if it's Madagascar, you might be eating dinner. It is winter and evening in Madagascar. So you see Luke and Laura on the screen all bundled up and sitting in the dark. That's why. So I wanted to say thanks for joining. These webinars have been a really, really lovely moment in this whole situation for me and for Pivot. It's been a chance to connect the people who care about Pivot all over the world to the people doing the work in Madagascar. And so often my job is being the bridge and saying what Luke or Laura might say if asked directly in conversations in New York or Seattle or wherever I am talking about Pivot. And now you can just talk to them directly, which has been amazing. So as Amy said, we are going to take the pause on talking only about COVID and shift to talking about the 3 levels where Pivot works and intervenes in the health system, the public health system: community health, primary care, and hospital. And we really believe deeply that you have to do it all so that transformation is possible. And so this is going to be kind of a deep dive with the deputy director of each of those areas of work leading a session each week. And we're starting with community health because we believe it is really the backbone of our work. One important point of reference is that 70% of the people in the district where we serve, Fianarantsoa, live farther than 5 kilometers from the health system. So 3 miles, which of course, if you had a paved road and a car, would be no big deal. But because most often it is traveled by footpath, there's only one tarmac road that bisects our district and most people live well off of it. That could be half a day's walk, especially if you're taking kids with you or you're going farther than that to a health center. And so even if the health centers are wonderful, which we are working on them being, there's a large part of the population that does not have its needs met by that, or frontline work that could happen right at the community level that could prevent people from having to take that walk. And so community health really is the answer there. And we think of our community health workers as frontline health workers. I'll share that in Madagascar, a community health network exists. You'll hear Luke describing that there are 2 community health workers assigned or elected per Fokantani. A Fokantani is a cluster of villages. And so what we're trying to do is enhance that. And we've been doing that for 5 years. And you'll hear Laura talk about the additional enhancements we've added in one commune in the last 6 months and how we've seen adding a proactive walking network of community health workers to the stationary ones that sit in the health post and see patients has really done amazing things for serving the population's needs. So we'll be thinking about both of those things. The third panelist today is Dan Palazuelo, and he's serving as our community health advisor right now. He's a physician at the Brigham and been long part of the Global Health Equity Division in Boston. He's worked at many Partners in Health country sites, and I had the pleasure of being with him in Madagascar in the month of February. So he's going to talk about global health the world over, but particularly what he saw in Madagascar alongside Luke and where he thinks the potential lies. So I'm really excited about the panel today and about the chance to share these three voices with you. A couple of other housekeeping kinds of things. We'll probably use some acronyms and I want you to be able to follow them. So CHW is community health worker. That's sort of the English vernacular. An AC is an agent communautaire. So that's the French way of thinking of a CHW. And then Pivot added a cadre of supervisors to the community health workers who are nurses and midwives. And that's been an important enhancement to the program that we've been working on for years. And we refer to those people as ACCs. So you'll hear Luke probably talk about all three. I mentioned that a Fokantani is a cluster of villages and a commune is an organized element within a district. So there are 13 communes in the district of Ifanadine where we work. You'll hear us talk about different communes, Ranamafana commune, Kalalalina commune. If anytime we're not making sense, just pause and ask us. Let's see. I think that's all I wanted to say in terms of getting us ready to think about community health. I will say that we're always so grateful to have our colleagues on the line who speak English as a second or third language, but I do want to acknowledge that that can be challenging for them. And so Luke speaks great English as a third language. And if ever he would rather answer a question in French or lean over and have Laura help with translation, you'll hear that going on in the background. And we are really encouraging that to feel comfortable. Okay. So that's that for community health. The COVID update is as follows. As of today, we have 371 cases in Madagascar being reported alongside 2 deaths. Those are the first 2 deaths and they've just happened in the last couple of days. So we're headed where we suspected we would be. And we are doing a lot around the preparedness and the thinking about this as we've talked about in previous sessions. But the case count in Madagascar lingered at sort of the 180 mark for quite some time because testing is so limited, about 2 new cases every day or every 2 or 3 days. And now we've jumped to 20 to 40 new cases every day or every few days. And so 371 is where we stand right now. Still no detected case in Ifanadine district where we work, but that is largely because of those 13 tests that we have, being all the rapid tests we have access to. And we are working on trying to capacitate a lab for being able to do PCR in our district, but that's not underway quite yet. So we stand assuming that COVID is with us in Ifanadine, but not knowing for sure. All right, with that, I am handing it over to Dan. Thanks.
Thank you so much, and thanks so much to the Pivot team for the opportunity to be here, and also for recently hosting a visit to Madagascar, where I had an incredible experience. Coming back, I flew through Doha back to Boston, and the COVID problem that we're having now had not been declared a pandemic and now has exploded. But I was really blessed to, before we went into complete lockdown, to be able to be in Madagascar. And I hope that a lot of you guys have that opportunity too, because it's truly a special place and the work of Pivot is quite special too. A little bit about myself. I am a physician. I work on a lot of times on the front lines, even in the US health system. Just a couple of weeks ago was on the COVID wards here at the Brigham. And I also work, as you've heard, in community health. And I'd like to review with you a little bit about why community health, why in Madagascar, and why Pivot. But while I'm doing that, I'm actually going to share my screen so that I can take you on a walk with me here in Madagascar. So this was taken actually with a 360-degree camera, which you can see. This can also be put into a headset, and you and I will be able to, you'll be able to walk with me through the Malagasy countryside while I describe to you these things. I can also move it around, and occasionally you'll be able to watch me, for example, or go forward. And here you see me very gingerly trying to cross a very slippery and wiggly bridge. Normally I'm much more nimble than that, but I think, you know, once you don't really know somebody until you walk in their shoes or slip in the mud that they might slip in at some point. So why community health? Community health, as you heard, is incredibly important for achieving good outcomes. Community health workers are, very simply put, a bridge to care, at least when they're best positioned that way. You know, recently I was interviewed by somebody who asked, you know, wanted to know about community health at PAH and other places. And she said, oh yeah, I spoke to someone in Geneva and they told me that community health workers were just kind of a short-term staffing model before they could get enough doctors and nurses. The truth is that is fundamentally wrong. With all due respect to my colleagues in Geneva, there are things that community health workers cannot, that they do that doctors cannot do. It's what's famously been called what doctors cannot do. And what is it that doctors cannot do? Well, if you ask doctors, they'll tell you nothing. But what they cannot do is be in the communities, be from the communities, and have the time to connect with people on their timetable. So sometimes people also talk about community health workers being a mechanism for short-term cost savings. You know, community health workers are cheaper than nurses, so they're the ones that can do all the injections. Or they're long-term cost savings. They're gonna get us better outcomes over the long term. For me, the long-term cost savings are the more exciting and important part of community health work. When you have people who are engaged with communities at the place where health and healing actually occurs, which is in the home, in the community, dealing with community complexity, then you're able to, I think, achieve something that goes much deeper into the healthcare delivery process. It also provides a platform by which to begin to address social determinants of disease. So why in Madagascar? Well, Madagascar is a fantastic context. The areas where Pivot works, as you see here, it's incredibly rural. I mean, our team here, we did this walk that you're watching now for 8 hours. I was exhausted. It took me 2 days to sort of get over it. They do this all the time, day in, day out. And as you see, we're walking, we're connecting with people, we're saying hi. It says a huge amount that if you go and show up, that you're validating that person's humanity. You're validating that they're important enough to receive a visit and to receive care. When you live this far out, in addition to suffering poverty because of lack of access to markets, you also lack access to meds and information, and community health workers are incredible conduits for those. And so then finally, I'll finish by saying, why Pivot? Right? There's a lot of groups that work in community health, and Pivot shares a lot of similarities to the organization where I work and grew up in, Partners in Health. They are also unique in the global health landscape, and that's why I feel really honored to have been able to share some space with them for a little bit. First, they're incredibly dedicated. You know, it's all throughout global health. There's so many groups that fly in, fly out. First of all, that's terrible for the environment. It's terrible for communities. It's also just, it's terrible for the message that it sends. When you are dedicated, being thoughtful and smart about a context, you can go deep and broad in ways that is otherwise not available. But then in addition to that, there's lots of NGOs that stay in a place and become a part of the community. Pivot is also incredibly hungry for results and change. And they do this by being very aware, and probably better than I've seen in most NGOs, of data and the way data systems work. And you can learn a lot about that in their many publications, and many of the systems that they're using are incredibly innovative. And then finally, you know, beyond publications, beyond data systems, which can be a little bit academic and insular, they're also very well connected to other NGOs. For example, there's this group called the Community Health Impact Coalition, of which Pivot was one of the founding members. And the Community Health Impact Coalition, you can learn more about them at chwimpact.org. Community Health Impact Coalition is a coalition of community health worker groups that share best practices, data, and advocacy efforts to improve the community health landscape. And for example, recently, through a program that we call CHW Advocates, and it has its own website, chwadvocates.org, we launched a PPE for All campaign. In COVID, for example, a lot of times CHWs are just sent out into the front lines, you know, with little concern for their own personal well-being. And in COVID, frankly, that can be quite dangerous for both the worker and patients. But we've launched this campaign saying, you know, don't just think about the health worker, think about the health work being done. And if anyone, any frontline worker is seeing patients, then they should also get the full protections. And that's something that's possible with collective action, like through Community Health Impact Coalition and the PPE for All campaign. So thank you so much for the opportunity to share a little bit of this. Here you see me with a beard. I had to shave it because now I wear N95 masks for most days. And in case you're wondering, I did not fall once, came close, but my boots did get very wet. And that is a little lesson for you guys. Next time that you're in Madagascar, make sure you wear gum boots and not regular boots. Thank you.
Thank you, Dan. That was our first experiment with virtual reality. And I'm just going to call it a success from my standpoint, because what a totally refreshing way to think about this while we join you on a walk and while we see Lanto leading you through the countryside. That was beautiful. We are going to have 90 seconds now from this PPE for All campaign that Dan mentioned, just to invite you into the perspective of the community health worker. The woman that is going to be highlighted is named Fetty, and she works with Luke and the team with Pivot, and she's first up in this 90-second clip, which we prepared for a big advocacy moment that Dan described. So after the 90 seconds here, where Fetty and other community health workers around the world and all of these peer organizations talk, I'm going to hand it over directly to Luke, who is the Deputy Director of Community Health for Pivot and one of our very, very first employees in 2014.
All right, Tara, can you just tell me, are you able to see Fetty?
Yeah, it's great.
Okay. Just give me 1 second here to make sure you guys are all going to be able to hear this well. Sorry. Okay, here we go.
My name is Fiti. I'm Unita. Monica Adiambo. Award Nyakira. Frida. Unita Doyo.
My name is Caroline Mudoni.
I'm a community health worker. CHW. I'm a community health worker. We, the CHWs, are the frontiers in COVID-19.
We are linking the community with the hospital.
We are the key to building trust.
And when we are not going to meet with our clients because we don't have PPE, we are going to put the community in the risk of getting malaria,
HIV infection,
and deaths of under 5,
maternal, perinatal deaths, immunization defaulting.
We work from house to house. So when we go there barehanded, how do we look? People whom we visit see us as if we are the people who are transmitting this disease.
Without the protecting devices, I'll put the community members at risk. At the same time, I'll also be putting myself at risk.
The biggest challenge responding to COVID-19 has been like essential protective material like masks and gloves.
The pandemic is real.
I'm advocating for fellow community health workers like me to be given PPEs.
We need protection like other health workers.
Why are we not being considered as health workers?
I need to protect myself. At the same time, I need to protect the community members.
Minus the protective, we can't do the work properly. How do you want us to be safe? We are unsafe. Give us the PPE.
We need to fight this virus.
My name is.
All right, Luke, take it away.
Okay, so my name is Luc. As Tara said, I have been working with Pivot since 2014, so this year will be my 7th year with Pivot. So I am the Deputy Director of Community Health. So now I will give you some background of our work about the community health and give you some introduction about the new approach that we make in the district of Ifanati, I mean the community, and give you some challenges about what the CHWs are facing on the field. So Pivot has had a community health program since 2015, and we have been working in 7 communes, focusing on child health, specifically malnutrition, pneumonia, diarrhea, and malaria. So we also support maternal and reproductive health and infectious disease such as tuberculosis. So in 2018, our research showed that despite our efforts to reduce financial barriers, our coverage and access was truly limited by geographical barriers. But I will explain more later about it if necessary. So this situation led us to transition our approach and align more with the WHO as well as together groups such as SHIC to start a pilot of community health project. So to start, it is important to give you what community health looks like in Madagascar. So I think at the beginning, Tara said that here in Madagascar, there are 2 CHWs per Fukuntani, and Fukuntani is a groupment of villages. They work, I mean the community health workers work in the community health site, and they are volunteers that are in fact selected by their community. And in our pilot, we have added a few new components, like we are recruiting more CHWs to match population and geography. We are financially motivating them according to the minimum salary in Madagascar. And we are introducing proactive care so that they can visit each household and actively find and treat patients. As they are actively finding cases, they are also raising awarenesses on specific health issues. They are screening for tuberculosis. They are meeting unmet needs in family planning, and they are understanding vaccine status. They are linking pregnant women to a midwife and at the health center. So as we can see, CHW is a pillar and the base of the health system in Madagascar. They need to be recognized for the essential work they are doing, and they also need to be accompanied. This is why from the very beginning, since 2015, I think, Pivot recruited CHW supervisor who are clinicians like midwives and nurses that are interacting with and supporting CHWs on a monthly basis, both in the field and at the health center. So the supervisor do direct observation of clinical care provided by the community health worker and assess their needs in training and additional support for case management. And I would like to take some of time to and recognize some of the challenges of CHW are facing. Previously, as they were volunteers, they were not able to financially sustain themselves and that they dedicate enough time to providing care. So CHWs are nominated by their community and therefore tend to be trust, but also older individuals. This both has advantages and disadvantages. So we have had to adapt our approach to accompanying them. CHWs end up being very busy, especially when they are multiple NGOs who want to interact with CHWs. We need to focus on coordination and actively think about workload and capacity. And finally, the last challenges I would like to share is the distance, as Dan show us, that needs to be crossed to visit every single household in the month. How to balance the time lost to walking and the precious time spent with the family. I think that's I can talk about it.
Yeah, that's a good general point. So Tara, if you don't mind, I'll take over on some broad points and then try to respect the time to hand over to questions. So I would like to present the work that that Luke was talking about, our community health program, into a vision of universal health coverage. So I'm gonna try to share my screen. If you give me a minute.
While Laura gets her screen ready, I think everyone knows she's our national director. She's been in that role since August, but also been with Pivot since day one when she and Luke joined me in a giant leap of faith to start Pivot together way back then. Both going strong in year 7, so thank you all. And one thing Luke was talking about, I wanted to make sure people know, just for a point of reference, is that the minimum wage in Madagascar is about $70 US a month. So if you're just sort of thinking about what are people being compensated for in terms of this incredible amount of work they're doing, that's what we're shooting for. Okay, go ahead, Laura.
Thank you. Sorry, I jumped right in, didn't even take the time to present myself. Can you guys see my screen? Okay, perfect. So to kind of pick up on what Dan had said, Pivot is obviously, focused on implementation, clinical care, but we are data-driven. We are lucky to be surrounded by people like Matt that some of you have met, and some of these voices from the field, and research is a very big part of our work. And so I would like to show you this graph, which is truly for us gold. And has completely shifted our approach first towards UHC, but also community health. So if you look at this really briefly, we've got one graph on the left, 2014, and then on the right, 2017. And in blue, we've got a line of utilization per capita, so the number of times people are going to the health facility in a year over time. And in the x-axis, we've got distance from the health center. So you can see in 2014, when Pivot started, before we had our reimbursement project, we could see that people both inside and outside our catchment area were more likely to perhaps access care less than once a year. As they were closer to the health facility, you can see that kind of dip between 0 and perhaps 2 kilometers. But people were not accessing care. Then in 2017, we've got our reimbursement program, we know from our data that we are reaching more people. The line in blue inside our catchment areas shows that some people are accessing care more than 3 times in a year, based on obviously episodes that someone might go through in a year. But look at that big dip, and that's 5-kilometer mark is what just kind of shifted things for us. So we realized that no matter what we had done to remove financial barriers, to increase access to care, geographical barriers are in fact more than ever a barrier, and that we needed to shift our approach. And so getting care past 5 kilometers, getting care to the community, proactively seeking patients is what we wanted to do, and therefore why we introduced proactive care. I want to nuance what we mean by proactive care, in the sense that we actually haven't fully shifted to proactive care. We are implementing what we call a 2-pronged approach. We wanted to respect and actually support the ministry's system, which is based, as Luke mentioned, on a community health site. And we didn't want to completely shift behaviors towards access to care. And because of the geography, we like the idea that in the case of an emergency, someone knows where to go in their community, that a community health site could really be the basis for where care happens, but still, meanwhile, introducing proactive care. So at one point in time in the commune of Renomafana, like PPE for all, in the commune of Renomafana, there is a community health worker that is working at a community health site, available at all times, and community health workers that are actively following the circuit and going to visit households and find children under 5, women who need care. So I want to share some of our initial results really quickly. This graph shows the evolution since October to March of the number of children under 5 seen by CHWs in the commune of Renomafana, which is where we started the pilot. And interestingly, you know, obviously we knew that we were going to be seeing more patients. That's not rocket science. I mean, we were actively finding patients, but we're actually, you know, we were surprised to see we were still seeing a lot of patients being seen at the community health site. So that really reinforced the fact that we need to keep the community health site, and community health workers were and are finding patients and going to see households. So the percentage of increased access to care, let me pull up some of those numbers. They're really quite impressive. So over that period, community health workers saw more than 3,600 children under 5 and treated them. And that's a 283% increase in utilization based on the previous period. So that is really, truly impressive. And when we're comparing it to other communes that haven't had proactive care, we were seeing perhaps, you know, an increase in 12% in care. So that was important to be able to consider variations in perhaps seasonality of malaria that then influence utilization. So we're very conscious that this proactivity, the idea of, you know, walking miles on end, is only possible with motivation. And by recognizing that the CHW is as important as the health facility in universal health coverage in UHC, and we are, you know, fighting the fight, even though it can be controversial, making sure that they get recognized and paid at a minimum salary. And so we're doing this in partnership with the ministry. They're looking forward. We're submitting our initial results and we're publishing some initial results. So this is a really exciting time for community health. And truthfully, more than ever in the space of COVID, really makes that link more that is necessary. Like you said, Dan, the distance, the lack of information, CHWs are part of this fight. they're key to making sure people understand what COVID is. They're key in providing care. They're key in ensuring those referrals if need be, and they're going to be part of the fight. So I will end here because I know we're past the 30 minutes, and hand over questions because there are a lot of interesting ones coming in.
All right, great. So I am going to try to make sure we get a question out there for everybody. I think the first one I'd like to ask is from Ronald Pust at the University of Arizona. Ronald, if you are still on the line, you can wave your virtual hand at Amy and she'll unmute your mic.
I don't think we have many more, Tara.
Oh, we don't. Okay, well, I will ask his question for him, but we'll just keep it short since he's not on. So the question is about the area and size of Pivot's community health program, and then the maternal mortality ratio if known. So Laura, why don't I hand you that one, and we can just say what we know and connect with Ronald later to see if that answered his question.
Yeah, absolutely. So Pivot is interestingly positioned to actually be able to understand exactly our population. In 2014, Pivot did a demographic health survey at baseline, and we've been doing longitudinal surveys to understand the socioeconomic health indicators of the population we serve. And so for the district of Ivanadin has about 200,000 people. And in the community health space, as Luke mentioned, we're working in 7 communes right now. And so that represents, in terms of target population, about 17,000 children under 5, more than 22,000 women of reproductive age, about 4,000 expectant mothers. We know what the mortality ratios are, both for children under 5, infants, and maternal deaths as well. And it's a challenge, but it's also, you know, it's important for us to know this information. So we have 1 in 14 women that are dying related in issues related to pregnancy or during pregnancy. And so again, these are very shocking numbers, and most of these deaths are due to late access to care, distance, misunderstandings around delivering at a health center versus delivering with a traditional birth attendant. So all of these answers and could be in the hands of community health workers in making those links. So those are some key statistics, I would say, around community health and population demographics.
Thank you, Laura. Let's go next to Meg, if Meg is still on the line. And I would say, Luke, I would like this question to be for you.
Hi, Luke. So after an amazing 7 months piloting this new proactive care model, what are the CHWs telling you? So when you chat with them about spending their days walking now and looking for sick kids, what are the biggest positive parts of that experience, and what are their biggest challenges?
So one thing that we can see in them when they have a meeting with them, so they are very happy. First of all, because of because we give them the minimum of salary per month, so they are happy to be like one part of the worker in this district. So it's very important for them to receive this motivation for them. And secondly, they are very excited to did them work at when they are on the field. Why? Because they would like to give more effort to treat the patients. But one challenge is that we can see too, and they told us, is like, we saw that the CHW is not enough to did the work. For example, they saw a lot of patients at the community, at the when they did the home visits, they can't attend them all. I mean, for example, one CFW should visit like 100 houses per month. They cannot attend it because they should do like a follow-up for some kids, or they one kids should have like 2 follow-up during the month. So it means that there is some houses where they cannot visit. So I think that's one of the big challenges that we will think on for the future.
Yeah, it's been great actually, because we've been having focus group discussions with the community health workers to really understand. First of all, I want to recognize just Meg actually helped us launch this project, so it's really great that you're able to join us, Meg, and it's a delight to be able to talk about this. I would also, to what Luke said, I'd like to add the recognition of just being recognized as in the PPE for All video as like a frontline worker, as a health worker, and that's given them a lot of pride. Another nuance in some of the work that we've done is we've pushed really hard for supervision to be more frequent, and that's been really appreciated as well. That's really positive feedback. It's difficult in practice, and we want to transition definitely towards having a peer supervision effort because of the feedback that they're giving us on this more frequent supervision. Before, we supervised every quarter, then we did every 2 months, and then we did it every month. Not because we didn't trust the community health worker to do their work, but actually because they want to be able to get the advice, and they want more interaction. It makes them feel more recognized for the work that they're doing. So it's been a very interesting shift in dynamic. Yes, do you have another question there, Meg?
No, just thanks guys for your work. Good to hear about it.
All right, I'm gonna go now to Murdy. She has a question about incentives and community health. And Dan, I think this one is for you. And let's answer it not just for Ifanadine, but for the work you've done the world over around community health. So sort of how you've seen different incentive programs set up and what it means to be paid a real wage for a real job. Murdy, are you still on the line?
Yeah, I'm right here. Yeah, so my question was just, do you find that you all need to incentivize clients to seek care, just because, as you all mentioned, it's very challenging to get to the health centers if they are far away and you have children, and there are just a lot of variables at play, and what might those incentives look like?
Yeah, it's interesting. I thought that first you were going to ask, how do you incentivize community health workers to work? But I think what I'm hearing in your question is, how do you incentivize patients to get care? So it's luckily in global health delivery, we think a lot about these questions around behavior. And there's luckily a growing literature, a lot of it not from the medical literature. This is largely from the business management literature, even psychology literature. And it's also got very popular in the popular press around, you might have heard there's a famous book called Drive, What Makes Human Beings Do Different Things. There was, of course, that famous book Nudge, how you can change people's behaviors with different sort of systems level changes. I think the most important thing for groups like Pivot and Partners in Health is that we try to think about the behavior of our patients, impoverished people in rural Madagascar or wherever it might be, and our community health workers. We try to think of them as actual human beings, right? A lot of times there's this incredible phenomenon that happens where people see them as operating on some other principles, and you get this fantastical thinking. Classic things that you see happen are poor people in rural areas have a different cosmovision, that because they, you know, might have spiritual practices around different rituals, or because of historic reasons or whatever, that somehow they then make decisions differently. The simple truth is that most human beings, especially in a modernized world where really most people live in what we understand is global civilization, it's very similar processes are at play. And the decisions that people make are very similar to the processes that we use. So, you know, one of the classic things people say is, oh, is it very difficult for people when they don't believe in Western medicine to get them to seek care? And I say, oh, of course, yeah. The hardest patient I ever met was my mom, because she loves homeopathy and herbs and chiropractors. And she always looks at me cross-eyed. She's like, you doctors, you think you know everything. My mom and I love each other. We're great. We're best friends. But, you know, what I think we have to do is create systems that are patient-centered, which is, what would someone in rural Madagascar want? It's the same thing you want, which is care that's effective, care that's safe, care that's affordable, care that's available. And then when it comes to questions around preferences, someone might call them cultural or otherwise, you can adapt that as a level of patient-centeredness. So one of the classic things is, you know, in Ethiopia, a lot of women were not delivering in, this is also true in Partners in Health, they were not delivering in the maternal waiting homes. But the maternal waiting homes were dirty, they didn't provide food, there wasn't there wasn't access to surgery and transfusions if you needed them. And so women didn't go. And people said, oh, that's because they have these, you know, animist philosophies. It's like, no, it's because they're rational. Who wants to give birth in a dirty, dangerous place, right? You clean it, you make it nicer, and then obviously it gets a lot better. However, as we've seen here, that's sometimes not enough. You have to think about transport. You have to think about other questions of how they're making decisions every day with the very limited money that they have. And then you have to add other interventions to support them to better engage in care. So, you know, that might be transport support, that might be food packages, that might be, you know, sometimes it's physical accompaniment. We also have to be smart about different interventions, maybe put in communication systems. Maybe some people are even entertaining the use of drones to deliver some very basic small packages of stuff. Obviously, you can tell I love tech. I don't think tech is the only solution, but when well integrated into delivery platforms, it's very powerful. And just as an aside, 2 more seconds, community health workers should be paid for their work. Another fantastical thinking is that community health workers are motivated by community sort of applause. Sure, they are. We all are. But that doesn't take away the fact that they have to put food on the table for their kids. And applause does not feed their children. So you have to pay them for their work. How much to pay them? That's a delicate art. And that's something that, you know, we often go into deep conversations around. But big picture, avoid fantastical thinking, understand that all human beings are just trying their hardest, and the simple act of reaching out and supporting people is transformational.
Thank you, Dan. Can I add one thing? We, you know, incentives for bringing people to seek care is something that we think about a lot, especially when, you know, Pivots first started, the utilization rates were so low. We were talking about 0.3 per capita utilization per year. I mean, that's less than 1. It's just, it's hard to think about, right? Like when you're sick, you at least assume that once a year you'll have at least one contact with a health practitioner. And so we've definitely, I think one thing I'd like to add to what Dan said is communication with the client. And so most recently, you know, we were thinking, how come we have so many women that are coming to the health facility for their first antenatal care visit? So we're reaching like 96% of women in their first antenatal care visit, and then boom, complete drop. They don't deliver at the health facility. What's happening? And so, you know, instead of just looking at the numbers, sometimes the best thing is to talk to the person. And so we did this, the monitoring and evaluation team did this interesting research where they were talking both to women who've delivered at home and delivered at the health facility, and understand why, what were the reasons what is behind their health-seeking behavior. And just like Dan said, obviously the welcome that they're going to get actually played up really high. So it's not just about the stuff, but it's also about the person and the interaction that they're going to have with people. So it's not as simple as, you know, how much incentive can we care, but how much of an environment can we create that actually promotes, you know, dignified access to care.
All right, thanks, Marty. I let Dan start because I hoped he would do that, start at the beginning of time. It's one of my favorite reasons to take a long road trip with Dan. All right, so I think that it would be nice to take Kathleen's question and let all four of us answer it as a way to close out, just because we're getting close to the top of the hour. And it's a question that we can maybe each take a minute to reflect on. And Luke, why don't you start? Let's go, Luke, Laura, Dan, and then I'll close out the webinar with my answer. Kathleen, are you there?
I just gave you permissions, Kathleen, if you'd like to share your question.
I think you're on mute though, Kathleen. Kathleen, we see your name, but we also see your microphone on mute.
Maybe we can just ask it for her, Tara.
I feel like Zoom should solve this problem. Like, you know, just unmute people when they're trying to talk. Okay, Amy, so it's not all my voice. Will you ask Kathleen's question?
Sure, yeah. Kathleen would like to know from all of you, given the additional challenges COVID-19 is posing to your team, what worry is keeping you up at night right now?
For me, one thing that I'm very worried about is like the protection. Like, I mean the PPE. It's very difficult for now to find it right now. And for example, now we would like to support all of the health center, but also the community too. But it's very difficult to find more PPE for all of the district. Mm-hmm. So for example, here we have a lot of CHWs and we would like to help them on, but it's very difficult for us, I think. Yeah. Don't know if you want to add some, Laura.
I would say what's most on my mind right now with COVID is more from a strategy perspective. 2020 was going to be an important year for Pivot, no matter what, because we're doing this big shift in our partnership with the ministry, implementing UHC in Ifanajin district in collaboration, hand in hand, and in alignment with the ministry. And so I want to make sure Luke and I stay up at night on like, how are we going to deliver on that and COVID, knowing that for our COVID response to work, we need UHC more than ever. They're not separate, but yet all of our resources and energy are just being diverted towards making sure that nobody, you know, to prevent the infection, prevent complications and deaths. And that's a hard one for us. Yeah.
Want me to go next? So COVID changes everything. We don't know the full extent of it yet. But I worry right now. There were many things I worried about before, but I'm also a little bit excited because I think that for years we've been talking about how we are all connected to each other. You know, illness of someone anywhere is illness of everyone everywhere. if one person doesn't have insurance, then none of us have insurance, right? And for a long time, it felt like we were screaming into the abyss. But yet now, I think the world recognizes this viscerally. There's this famous theorem of the shock doctrine, that once you have a shock to the system, you have the opportunity for great change. And we now can utilize this opportunity and this realization that people have come to help bring in and usher in a world more aligned with our values. And I think Pivot has a lot to offer us here. It's not that we're also just connected to each other, we're also connected to the planet, and we have to think about how our actions affect our environment. Global warming is very real, and it has disastrous effects for human beings and plant life and animal life. I worry, though, that as much as there's this disruption that can create change for positive, others can create change for negative. We're very much at risk for ushering a new age of totalitarian rule, for a world based on fear and closure and moving backwards. So as you know, I wrote a blog talking about how the world needs to pivot, and Pivot gives us a great example of a lot of ways that we can learn and work in a better world. But I think that's going to require significant effort. And I hope that all of you guys listening into this realize that you're part of this. You're not just listeners, you're actually recruits. Please don't let the world get worse. Let the world help us make the world better for kids such as the one behind Tara right now.
Thank you, Dan. I thought I would just scoot over so you can see I'm slightly distracted. That was very beautiful. I have a lovely babysitter, but Zoe is a force into her own. So sometimes she breaks through that barrier. Okay. I'm going to say, I sleep better at night knowing I'm in this with you guys, Luke, Laura, and Dan, and Amy, and the 29 people who joined us today on the line. I also, because Zoom is so weird and you can see yourself talking, realize my eyes are kind of bloodshot. I'm not actually sleeping that well, is the truth. Yeah, it's something to lead a global health organization during a global health pandemic. Yeah, I feel like every once in a while. I also have a preschooler who's being schooled virtually, which is just not working. So yeah, I feel like Dan feels, which is that we've never had an opportunity like this in terms of connectedness across the world. And I really, really hope we don't blow it. And I don't think we're going to. I feel glimmers of hope all around. And every time we have one of these and I feel like our community gets a little bit closer, I feel better about the sort of collectiveness of our experience in this world and this new fragility that we're all really aware of. So I hope that, people like Luke can keep screaming from the mountaintops what needs to change. And, we have solutions and we have leaders like Luke who can take us there. So that feels really important to me. And, then just in general for me, I don't want to shrink Pivot right now. I want to achieve the ambitious goals that Laura just laid out. I want a bigger budget with more funding than we've ever had before. And I know that COVID is so complicated for people because they're worried about their own family and neighborhood and wealth, maybe with weird volatile markets. And lots of people who support Pivot are in epicenters of the pandemic around the world. And so of course I want them to give locally as well, but it's a moment to lean in and be big about this and really help us to have this be a very important moment for Pivot in terms of achieving universal health care. Not to say the story of COVID for us was having to shrink an organization and sort of scale back our agenda. So that keeps me up at night because those are big chances to take. And, we make commitments to communities when we begin work. We remove user fees and we say we're going to stand by you in solidarity for the years to come. And I never want to renege on that. So I can't do that alone. And I am just very grateful to all of you for walking the walk with us and joining us today and always. I'll close out by saying that next week is primary care and the week after is our hospital system. And if you were impressed with today, you will be impressed with next week and the week to come as well. So thanks to everyone for caring and for being there. Goodbye.